everyone. This brings us to the live Q&A portion of the program. Dr. Seidner will be joining us momentarily, but right now I would like to introduce Dr. Tom Abell, who is joining us as well. Dr. Abell is a professor at the University of Louisville and works in the GI Motility Clinic at the University of Louisville Health. So thanks for joining Dr. McCallum and Dr. Tansel, and hopefully Dr. Seidner today, Dr. Abell. We have a few questions that came in, so we will do our best to answer as many as we can in the next 30 minutes. So let me just bring up some of these questions. Dr. McCallum, we can start with you. Carol has a question. Do you use small particle size food as diet intervention for gastroparesis?
Well, let me say if that means, over chewing and over masticating, I guess, yes. I think we would recommend more Ensure or Boost as a caloric supplement rather than spending hours, grinding up meat or solid material into small particles. But we condone certainly a low fiber and low volumes. We don't want the broccolis and the cauliflowers in there, and we don't want steaks and other challenges. So I guess we indirectly condone small particles. I'm not sure I'd go on a mission to buy a grinder and grind everything up every day, but one could. Smoothies or these things are certainly condoned.
Great. And anyone else who wants to jump in and add to these, please feel free. It's an open Q&A, so we'll just get that dialogue going. I do have a next question. Dr. Seidner, thank you so much for joining us today. Whoop, you're on mute if you just want to unmute yourself. Perfect.
How's that?
It's an open Q&A, so great.
How's that? Can you hear me, Andrea?
I can.
Dr. Seidner, thank you so much for joining us today.
I can hear me too.
You're on mute if you just want to unmute yourself. Perfect. Great.
How's that? Can you hear me, Andrea?
I can. Dr. Seidner, thank you so much for joining us today. I can hear me too.
Well, why don't we go with the next question who Kathy threw it out to all of you. How many patients do you see that also have dysmotility of the small and large bowel? How do the treatments mentioned today possibly help those?
Why don't we go with the next question who Kathy threw it out to all of you. How many patients
Tom, why don't you take that one?
Sure. Again, let me know if you can't hear me. I think it's sort of like, if you look, you will find it. The majority of patients have problems outside the stomach with gastroparesis, for example. And likewise, people that have small bowel or colonic disorders often have gastric. So I sort of look at it that the nerve and muscle they don't know if they're in a particular organ or not. They're just there functioning or not functioning. So it's pretty common to have a more widespread disorder. It might focus on one area for a given patient.
As far as treatment, I think it certainly is important to focus on constipation, and we treat that aggressively. I think when the small bowel's involved, we get involved with this entity called Sibo, small intestinal bacterial overgrowth. A lot of patients have this unexplained gas and bloating as part of their presentation, which is probably not the stomach. It's probably small bowel bacterial overgrowth breaking down foods and sugars in the small bowel. So I think a lot of us would be more aggressive towards breath testing or trying to address small bowel motility. beyond antibiotics. But I think particularly in scleroderma and connective tissue disease, the small bowel is a major player in the presentation of these patients.
Thank you. Dr. McCallum, I think someone mentioned, you didn't mention Procalipride in your med slide. What is the role of that for gastroparesis right now?
Yeah, I had it there. It's work in progress. It's like a lot of things that we do when we're trying to treat patients who have failed some of the standard stuff. We use off-label stuff. And so Procalipride's approved for constipation. We would be willing to try it, as we did with Tagazarod in the old days. Try it for gastroparesis. Tagazarod is actually back for women with irritable bowel syndrome and constipation. You could play with Tagazarod as well. I don't think there'd be any reason not to. I don't know whether any of the other panelists have had experience with it. I've not selected it out alone to try, but I think it's on everyone's agenda, and I'm sure the pharmaceutical company is going to eventually do a gastroparesis trial.
There actually is a trial by Yontok's group that was published, and the most prevalent side effect was nausea and vomiting, which is known, and there was one volvulus in the group, and it was a randomized crossover trial. So, I mean, given that, I mean, I personally like to start with 1 milligram of Procalipride. The standard dosing for constipation is 2 milligrams. So I like to start with 1 milligram. I think it's better tolerated in terms of nausea, vomiting, and then in terms of adverse effects. So I like to start at 1, and sometimes if they have a flare, I'll increase it up to 2. That's my use, and I know that Tom, Abel, you use it. I don't know if you want to talk about your experience.
Yeah, we used it 20 years ago when it was in trials in the US. Now that it's then later approved in Europe and now in the US. I think, right, the Yontok study was generally a positive study. And since so many of our patients have more than one organ involved, it may be a useful drug. It certainly seems safe so far.
Okay, we had another question come in. How many doses of Zofran is considered safe?
Well, I think Zofran's had a bit of an extra push because of it's safe in pregnancy. So I think we're going to see a lot of people using Zofran fairly frequently. I go up to 8 milligrams 4 times a day, rarely, but I could be talked into it. Constipation is seen up in the ICU where they give it IV frequently. But I don't think the constipation would be enough to try to help people who are nauseated and don't respond to standard therapies. But no, I think up to 4 times a day is okay personally, but I usually go 3 times a day as my standard. Any other colleagues come in with that one?
Same as you.
That's pretty much, we usually 8 milligrams 3 times a day. Some people can tolerate the oral sublingual better. It's reasonably priced now. So it's a good drug, but some people don't respond.
Dr. Seidner, for Sibo, do treatment options change when the breath test is methane predominant?
Not that I'm aware of.
Well,
I suppose the methane, I suppose you may look for something that's more targeted at the anaerobic, so maybe metronidazole a little bit more. But beyond that, I'm uncertain.
Mental promotes neomycin more in the methane positive group. He feels that maybe combining Cipro and Fragile or Fragile with neomycin, 1 gram 3 times a day, is a better ticket in the methane dominated or methane alone people. But yeah, to get to methane, you have to have hydrogen anyway. So it's a combination anyway when you treat the patient. I don't use much Xifaxan, so it's too expensive for my patients. But I'm sure Mark believes that Xifaxan.
I didn't mention in my presentation combination therapy. Certainly, treatment's very often empiric. Some antibiotics not working and other ones being effective for a patient. I guess the other thing, of course, I didn't mention, but I think is pretty obvious is always check allergy history. You're obviously not going to want to prescribe something that somebody has a reported allergy to.
Great. Dr. Tansel, we have an attendee saying, I'm interested in health disparities and curious if you found anything in your current data regarding racial disparities, or will you be doing more research on this?
Yeah, so I mean, this is just like the first version of the survey, and it's still very much under, I definitely hope to expand it, and certainly part of the reason why I collected data on race and insurance and where they live and income was to look for disparities and see if that was leading to a lot of patients to seek more emergency care. But right now, the way that the data, it's still pretty small. Most 85% were white. So, I mean, this is a very little, so it was too small to really make a kind of conclusion if there was a race disparity. And the only thing that showed from the preliminary analysis is that low income did result in hospitalization, which to me makes sense. So that made sense, but certainly it's definitely an area I'm interested in and hope to expand in the second part of the survey.
Great. And a second question to that, I guess maybe a follow-up is your survey still does your survey still need participants? They say they'd love to help if you're still looking for participants, and how can they enroll?
You guys are wonderful. Thank you so much. Everyone was like such a good listener. I know everyone was on mute, but thank you. Yeah, so we've been just doing the survey in clinic, but both Tom and I feel pretty strongly that there's a lot of you guys and there's a lot of data and you guys are willing and we need it. And so we definitely want to expand it into an online survey, but we haven't done that part yet. So we have to kind of go through the IRB approval for that part. But certainly if anyone wants, I think I already got a pop-up email from someone interested. So certainly you can email me or Tom to maybe in a month or two, we may have a little more data, a little more to talk about.
Yeah.
And I will add that they can also reach out to the Oley Foundation and we can always connect them to both of you as well.
Yeah, this is Tom. We originally wanted to do it online. The IRB wanted us to do it in the office first and give them out so they could see some preliminary data. So now we have the preliminary data that Dr. Tansel presented, and our goal is to try to get it online, but that may take a little while. But sure, just contact us.
Great. This is a question, it says, for Dr. Abell. Status on your research on autoimmune GI motility disorders. Are there any other centers you are collaborating with?
Well, there are a number of centers that are very, very interested, including Mayo Clinic's published on this for years. I know Hopkins is working on it. We've been working. We've got some work related to our gastroparesis consortium. It's an ancillary study that relates to autoimmune factors, and that's also a big focus for the what I'm going to call the GPCRC NIH group that Dr. McCallum and I and many others are part of. So it's a hot area, and I think there's clearly an autoimmune component for gastroparesis in some patients, but it's where it is right now. We're still trying to figure out who those people are, how to best diagnose them, and what to do about it.
Excellent. Dr. Seidner, I have two questions for you from an attendee. They first said, thank you for your presentation on Sibo. So the first question is, there was a comment stating bile salts naturally help control bacteria, prevent bacterial overgrowth. For someone with biliary pancreatic issues and slowed motility, I am on several 2400 Creon, I'm not sure what that is. When I do take a bite of something, when I was able to eat more, I saw a positive result with biliary symptoms when I took them consistently. I tend to not take the Creon when not eating, which is more often now. But now I am wondering if it would be worth it to take Creon daily, even if not eating, to see if it may help reduce my episode of Sibo. It's a tough one.
Thank you for the question. First, the Creon, which is a manufactured pancreatic enzyme, is generally taken with meals if you've got maldigestion. So your pancreas is unable to make enough digestive enzymes. And so you do take it, clearly take it when you're eating and not in between meals. It's, to my knowledge, it doesn't have a direct effect on small intestinal bacterial overgrowth. You must recall that in most digestive secretions are generally complex compounds. So secretions have more than just the enzymes that are listed on the label, and the manufacturing likely degrades some of the other compounds that may interfere with bacterial growth, which happens more with I should say with pancreatic normal pancreatic secretions. And so remember, pancreatic secretions also have salts and bicarbonate to make the content of the bowel optimal for absorption. So I don't believe that your pancreatic enzymes will directly affect Sibo. Of course, if you're absorbing more nutrients, there may be less substance, less food for the bacteria. So I suppose it may be somewhat helpful. Often I like to tell my patients that everyone is fairly unique as far as providing recommendations for diet and taking the medications that we recommend to help you absorb your food more readily. So a lot of it's just a matter of trial and error. I guess a thought that comes to mind is that often pancreatic enzymes are not given in sufficient quantities. So it's important to make sure that you are taking enough enzymes if you indeed have pancreatic insufficiency. And I think I'll leave it at that and let some of the other gastroenterologists who are on the line contribute to the answer. I guess were there two questions? I heard you started that there were two.
There was. And the second question is for the Sibo test. At times, I start to show my positive results a little after when the test time would normally end. The doctor felt it was due to such delayed motility, that it was taking longer for the fluid to move through me. Have you seen this in other patients?
Well, I have not directly witnessed a hydrogen breath test in a long, long time. So I can't, directly answer the question as far as what happened during the performance of the test, which it sounds like that's the question.
Yeah, I think what you'd be thinking about is fructose. When you have a delayed onset greater than 90 minutes, or certainly greater than 2 hours, greater than 3 hours into the breath test, you're talking about fluid in the colon. It takes about 90 minutes to 2 hours to get to the cecum. And so I think if you're over 2 hours, I don't think it would be delayed gastric emptying. This is glucose. Liquid emptying isn't that slow. So you'd be thinking about fructose. Fructose is a different treatment than Sibo. Fructose is related to undigested sugars in the colon. So I think you'd be thinking about that. It's a different approach.
We have a next question is, my husband's gastroparesis is under control as far as pain, vomiting, etc. However, he is seriously underweight. He takes 2 to 3 shakes a day. He does eat solid foods suggested by nutritionists for gastroparesis. Any suggestions?
So seriously underweight means perhaps he's lost 50 pounds, or he's under 105 pounds or 110 pounds. Any objective data?
Nope, that's all we have in the question.
And he's nausea and vomiting, he's happy. Well, you may want to think about, taking on the appetite stimulant world before you get too excited. Some people might use Remeron as an adjunct. Some people might use Megace. Some people might even suggest marijuana, or Marinol might be more politically correct as an oral agent to stimulate motility. Stimulate appetite, and then we might look at his mental state. Depression is a major cause of weight loss. And, you may have to look into whether depression has come across him with COVID or other things. You may need to look at the role of antidepressants.
Another question we have is, if a patient has a J tube, can the test for Sibo be obtained without the endoscopy to obtain the jejunal fluid?
Well, I don't think many people in the country, maybe Satish Rao, I don't think many people in a given day are doing jejunal aspirates and doing anaerobic and aerobic culture. That would be less than 0.1%. I think most people are at the most biopsying the duodenum, but that's probably not as sensitive. No, I think if you can drink glucose, we'd have you drink it, maybe slower, but we'd still do a breath test with a J tube in place. I've never done a glucose breath test through the J tube, but I guess that would be a last resort. It's only just below trites as a rule. So you've got a fair bit of jejunum left, small bowel, ileum. You could probably infuse, maybe we usually give 100 cc's. So it's about 3 ounces. You could probably infuse that over 30 minutes and not cause any pain in the small bowel. You can't give it as a bolus. If you give 100 cc's as a bolus, the patient has pain. It's not the same as the stomach. But I think it can be done. I don't think people do aspirations and cultures unless you're in a very sophisticated setting.
We have another question from an attendee that is asking, my patients ask me, will I get over gastroparesis? Usually diagnosed as mild and often the younger ones, 20 to 30 age range. Can it resolve?
Well, Tom, you've had a lot of experience, idiopathic, which is probably what this young lady has. I assume she's not a diabetic. So, Tom, why don't you give us your update on?
Certainly. Yeah, great. Thank you. Particularly classically, if it's post-infectious syndrome, those usually almost always get better over time. Not 100%, because nothing's 100%. It really varies a lot. I think some of it is if they have other associated disorders, known rheumatologic disorder, migraine headaches, interstitial cystitis, fibromyalgia, some of these other we call them overlaps, make it harder to resolve the gastroparesis. So
Yeah, motility syndrome, Ehlers-Danlos, POTS.
Yeah, all those.
They be negative factors in a 25-year-old woman, and we see that. It's becoming more prevalent.
Well, it almost varies as much as every patient is unique. We call it idiopathic.
Okay.
I would say I mean, I think I understand what that practitioner is asking, and a lot of patients do ask, like, is there a cure? Is this my life? Like, is this my future? And I think there's still a lot that we don't know in terms of some causes and how to prevent, reduce, and early diagnose. So, I mean, I know Tom has done some work, shown that there's fibrosis, and so in the biopsy. So in terms of is there a cure? No, but generally there are ways that we can mitigate symptoms and really enhance their quality of life. And that's really what the patients, I think, are really asking is, will I be able to get married? Will I be able to have a family? Those are usually those questions. That's what's underlying it. Yes, the patient can live a full life.
Okay, we have a question. Why do some patients get recurring Sibo even after treatments? What can be done to help those patients?
Well, I would jump in first. PPIs are the commonest cause of Sibo in the world. So if your patient's taking a PPI for reflux or for miscellaneous reasons, that's blocking gastric acid, that's making the small bowel not as sterile. And these patients need to be given acid as well. So I give a lot of vinegar in the form of vinegar and apple cider or just vinegar alone. I try to decrease the PPI as much as I can to every other day or less. And we give our share of probiotics and low Fodmaps diets. But sometimes you're forced to have recurrent cycles of antibiotics, but that's not your first choice.
Yeah, I might just make an editorial comment. My practice is often in patients with short bowel syndrome, so my presentation was a little bit skewed in that direction. So I value Dr. McCallum's comments on someone who more typically has Sibo because of medications or motility disorder that he's used to seeing. That's important for some people in the audience and some practitioners.
Okay. And a question for Dr. Abell. Are you using IVIG for gastroparesis? And if so, what are the outcomes?
Okay, for very select patients that have neuromuscular problems who've failed devices and surgeries, and particularly if they have measurable neuromuscular abnormalities, most common one is a thing called GAD65, glutamic acid decarboxylase, or antibodies against sodium, potassium, calcium. Obviously, just from the sound of it, those aren't good things to have, because it means every cell in your body potentially doesn't do well. So for a very select group of people, we and others, Mayo Clinic, Hopkins, other centers have used intravenous immunoglobulin. Our experience has been of those highly select people that everything's failed on. What we presented at DDW this year was that about a little bit more than a third of those get quote significant unquote improvement at a year with IVIG. But it's a highly select group. On the other hand, the people that survive, a lot of people that respond, they all survive. Hopefully, people that respond, a lot of times feel it's been quite helpful for them. And we follow them and try to taper the IVIG, follow the neuromuscular titers, and work closely with our GI neurologists. A lot of these people also have autonomic Potts-like syndromes. That's been kind of we have several hundred people that are treated this way so far over the last decade. But there really needs to be a randomized trial. We totally failed in getting industry that makes meds to support us. So a randomized trial has not been started, to my knowledge, anywhere.
Next question, Dr. Seidner. For Sibo patient, if patient is unable to drink the sugar water because of esophageal stricture and has a J tube, could a sample be used from the J tube instead of going through the endoscopy for a sample?
That would be highly unusual. Dr. McCallum just mentioned only a handful of centers in the country are actually equipped, set up to take samples from the jejunum and handle them properly. He's got a wealth of experience of applying these breath tests, and he mentioned that he's never delivered one of these sugars to the small bowel through the jejunal tube. So it's a great question for which we don't have much experience. And I would just ask, if I was sitting with that individual, I'd look at them and go through the checklist of, okay, do you have risk factors for Sibo? And is it worth just trying one or two of the antibiotics to see if you improve, or probiotics to see if you improve? And of course, also, I think an important part of the conversation is, what are you taking in your diet? Dr. McCallum also mentioned a low Fodmaps diet. Some people are overdoing certain sugars in their diet that when they're not well absorbed in the small bowel and get into the colon, cause symptoms. So we haven't really touched upon that much in the presentations or our conversation, but I think you do need to take a step back. As Dr. McCallum said with his talk about gastroparesis, nausea, vomiting, we need to make a diagnosis first, and that involves some time talking to the patient, figuring out what's the most likely cause of their symptoms.
We have another question. What is the recommended medication for a child with delayed gastric emptying and EDS that suffers from nausea and recurrent vomiting?
What's the EVS or EBS?
EDS.
Epstein-Barr virus, you're saying?
I think Ehlers-Danlos, I think.
This is a virally induced gastroparesis. Is that what we're saying?
I think, I was going to say, Richard, I think it's connected flexible joint, Ehlers-Danlos. Probably.
LSEDS. Okay.
Type 3 problem.
So the patient who's failed has failed metoclopramide. Is that the implication of the question?
Yeah, I think they were asking for recommended medicine, which I don't know there's any recommended or accepted medicine for that complex group of patients.
No, it's we encounter a lot of pain in these patients, very severe postprandial visceral hypersensitivity, profound, and we have to go to all sorts of lyricas and gabapentins.
I think the question, one of the implications of the question was, are there any restrictions of the meds that you use in the pediatric age group? Because I think it was a child with the condition.
It was, what is the recommended medication for a child with delayed gastric emptying and EDS that suffers from nausea and recurrent vomiting?
And Dr. Seidner points well taken. Well, there's nothing approved for kids, and I don't think, which is a whole nother issue and an important one.
Well, we certainly try low dose erythromycin as a college try. Domperidone is probably not available in children, so we probably couldn't go to that. We would use low dose erythromycin. I use a lot of scopolamine patches behind the ear to try to maintain 3 days of coverage. And I look into her Reglan background. We use a lot of subcutaneous Reglan. There are patients who can tolerate a bit of Reglan orally. May not be enough, but only about 50% absorbed orally. Subcutaneous Reglan, 80 to 90% absorbed, and the mother can give it sub-Q. So we play around. We use Reglan as far as we can go with vigilance, erythromycin, scopolamine patches. I think all those are on the table.
Okay, we have maybe time for one last question. Is there any connection to mast cell activation disorder?
Tom, you played around with this a bit.
Well, there is. I mean, people that have known mast cell activation disorder definitely have GI motility symptoms. It's been suggested, and more than suggested, in some disorders like irritable bowel syndrome, mast cells play a role. And for 100 years, people have speculated that's part of the etiology of some motility disorders. So, but usually allergists and immunologists that make that diagnosis and help treat it.
Yeah, I mean, if I get a story of hives or itchy skin or red skin, I might get a urine histamine just to be thorough. Getting a serum tryptase really means you're in the emergency room vomiting with sort of an acute attack, so-called, mastocytosis, or just below that definition. So if you're desperate, you might get a urine histamine 24 hours, or you would get a serum tryptase if they are vomiting and end up in the emergency room. It's out there. I think abdominal pain is very prevalent, as much as nausea and vomiting is as well. Could get mixed up with cyclic vomiting. Cyclic vomiting is different than mast cell activation, but they may be confused.
Okay, well, it looks like we need to end it there. Thank you to Dr. McCallum and Dr. Tansel and Dr. Abell and Dr. Seidner. We are thrilled to have you join us today. I just wanted to remind everyone to head back to live stream A for the Oley Awards ceremony that is coming up next. So again, thank you to our experts for joining us today.
Pleasure. Thank you.
Thank
My
you.
pleasure. Have a good day.
Take care.
Thank you. Thank you.